Hello, and welcome to Hadassah On Call, New Frontiers in Medicine. I'm your host, Mayan Hoffman. Today, I want to start out by sharing some exciting advancements from Hadassah. Dr. Petru Paniota, a neurologist at Hadassah Hospital in Kerem, presented findings at the 2024 Forum of the Americas Committee for Treatment and Research in MS, showing that repeated stem cell injections had significant positive impacts on patients with progressive MS. Co-authored by Professor Dimitrios Krausis from Hadassah's MS Center, the study highlighted improvements in neurological function, cognition, and overall quality of life among the 23 participants without any adverse effects. Dr. Paniota emphasized the rarity of such notable improvements in progressive MS patients, suggesting a promising avenue for treatment. In separate research, Hadassah researchers led by Professor Dana Wolf from the Clinical Virology Unit conducted a study demonstrating the reliability of newborn screening for CCMV using pooled saliva tests. This approach, supported by Professor Maron Yansour and the neurology team at Hadassah, emphasizes the importance of early detection, particularly for asymptomatic cases, and suggests that this method could revolutionize global CCMV screening by enabling timely interventions. This screening strategy has the potential to significantly enhance long-term outcomes of infants affected by CCMV-related neurologic defects. For more information about these stories, visit Hadassah Stories website at hadassah.org/stories. That's hadassah.org/stories. Today, we're joined by Dr. Yechiel Gellman, a senior foot and ankle surgeon at Hadassah Medical Organization. Before we dive into our conversation, let's explore some fascinating foot facts that I discovered while doing some research. Did you know that each foot typically has 26 bones, with 14 of them located in the toes? Additionally, the skin on the soles of your feet is thicker than anywhere else on your body. Despite this, when you walk normally, your entire foot never rests completely flat on the ground. What are the most common foot and ankle issues, and how do you treat them? For that, we'll have to speak to the doctor. Welcome, Dr. Gellman.
Thank you so much for having me.
For sure. Now, I want to just get started by having you share a little bit about your background and what drew you in to specialize in foot and ankle surgery.
So, my name is Yechiel Gellman. I'm 44 years old. I am married to my wife, Geula, and I have 5 kids. We live currently in Yerushalayim. I was originally born in the United States, but I made Aliyah to Israel in a very young age. Ever since being a kid, I wanted to become a medical physician helping people. And I managed to do that by completing a master's in microbiology and immunology here in Hadassah, and then completing my medical doctorate here too in Hadassah.
Wow. So you've been here a really long time.
Yeah, for a while, yeah. Afterwards, I pursued my orthopedic residency, again here within the Hadassah Medical Centers. And after that, I continued to fulfill my subspecialty in the New England Baptist Hospital in Boston, Massachusetts, where I manage under the mentorship of my physician, Dr. Mark Slovenkai, to really understand the foot and ankle pathologies so much better. After completing a 1-year fellowship in the States, I returned to Israel, and ever since I've been a senior foot and ankle physician here within Hadassah, treating all of these grave conditions. The original drawing into foot and ankle surgery was mainly because of diabetic patients. I saw these patients in very grave situation, life and limb-threatening situations, and I wanted to help them as much as possible. That, in combination with lower extremity trauma, caused me to see the complexity in the biomechanical aspects of the foot and the ankle, allowing me to better people's life in order to improve their quality of life and improve their ambulation and just general well-being.
Amazing. I mean, tell me a little bit with regards to the war, as you brought up, people having injuries to their extremities. And I know it's something we actually didn't get to speak about before this interview, but are you seeing a lot of soldiers and others who have been harmed in the war right now? And what does that look like?
Unfortunately, I do, since a lot of the soldiers went in and received very high trauma explosions, and they were protected with their torso, with all of the suits and so on. We see much more extremity trauma. We see both in the upper extremities and the lower extremities. So we might see feet which are blown away, very complex fractures requiring very surgical intervention, very complex surgical intervention, and me innovating in that sense, doing newer or using older techniques for these uncommon and devastating conditions.
Right. And as you mentioned, they're hopefully always going to be uncommon. This will be something we don't see all the time. I'm assuming there are different kinds of injuries that we do see more often. So what are some of those common issues that patients come in, to you for treatments? And how is it that when, somebody has foot pain that they know, should I come in and something is really wrong, or, oh, this is just a little bit of pain?
That's a great question. We do see a very diverse kind of problems within the foot and ankle. These problems can range from simple fractures to more complicated fractures. It could be chronic conditions such as ankle arthritis. We could see deformity of the foot. We could see acute infections in these diabetics. So we really could see a lot of different pathologies. Even a common day in my clinic can consist of a young female patient coming in with complaining about or deformed for toes, which needs to be fixed because she cannot fit into the shoe itself, until a more acute, devastating inflammation of the foot with a diabetic condition and a more chronic condition of ankle arthritis. So you kind of need to move from one side to another and kind of shift your view in order to treat the patient. Now, what's acceptable and what's not acceptable is both by us and the patient. Some patients might not accept even a small deformity, and it might be very much hindering their life. And as I might tell my patients, it's like having a stone in your shoe. You need to take that stone off. And as long as you're not taking it out, it's going to be painful. So that's one option. And in other conditions, the people might say, I want to continue with this care. I want to continue with conservative, non-surgical treatment of these conditions. And that is very much a discussion, which I always do between the patient and myself, what the best avenue of treatment is for both patient and myself.
Fascinating. I mean, when you mentioned deformity, what causes a lot of times, you mentioned young women coming in. So what would cause the deformity?
So you could divide it up into two major groups. You can divide it into congenital forms and so on. People who have deformity, which are hereditary, came from their parents, such as a hallux valgus, the big toe moving outwards and stuff, which is a very common condition and stuff. For some people, it is a devastating condition.
Is that like a bunion?
Yeah, it is a bunion. The bunion is actual bone, which kind of...
Sorry, I need some layman terms, I didn't know what that was.
So the big toe turning outwards causes bunion, and that bunion could cause bunion pain. New research has showed that it decreases ambulation and causes people to have continued pain. And that could be a condition, a congenital condition, and therefore we would have the younger population. Other conditions might be acquired, such as due to fracture, due to ligament tears, and stuff like that. So we need to treat all of these conditions and kind of understand where the people are coming from in order to give them the best treatment, which is tailored for them.
Is it true that wearing high heels can cause deformity?
That is one of the risk factors, the many, many risk factors.
I don't want to know what they are, actually. So I understand that you also deal with children. How common are foot ulcers and sores and things like that in children?
So by children, it's not as common as you would think, unless you had a foreign body going in. But the more devastating ulcers are regarding the diabetic population. These populations, which are immunocompromised, meaning their immune system doesn't work as well, could really get into bad condition. They might lose their limb, they might lose their life due to an infection. We currently have a unit within Hadassah, a specialized, tailorized, a diabetic foot unit, which has between 12 to 18 patients at any given time with these people with infections of the foot. And these really people need our attention or close attention because they're very, very much medically complicated. And unfortunately, we see a lot of disasters too in that situation. So keep your feet safe.
For sure. People probably don't realize and we take it for granted that we get up and walk every day.
100%.
Yeah. So, tell me a little bit about the approach to diagnosing the issues. When somebody comes in and there's a complex foot or ankle challenge, what do you look for? How do you know what the problem is?
Great question. So first of all, I would just get to know the patient a little bit better, because really understanding the patient, his age, his medical condition, what he does, what recreational activities he does is very much important in order to tailor and really understand what this patient needs for us. Afterwards, I'd hold down into the pain issue. Where exactly is his pain? When does he have his pain? How does he experience it? To what extent it is, just to better understand the pain. Afterwards, I'd kind of jump into the physical examination. And the physical examination is extremely important in such a situation, since all of the structures are so much close to each other. Even moving an inch away is basically like going a mile away. So we really need to hone down to know where exactly the problem is. So we examine the joints, the tendons, the ligaments around there, and we really need to find where exactly that pain is coming. And only then does imaging come in. The imaging comes in as reimbursing whatever we were taught beforehand. We'd start off with x-rays and CTs to see maybe the bone, and later on, in order to see a more complex 3D view of the foot, we might move on for an MRI, because when taking somebody to surgery, you'd want to be as sure as possible that you're really treating the underlying condition and not working on the side.
Makes sense. Have there been many advancements or innovations in the field in recent years? And if so, what are those?
100%. So I would kind of divide it up into two major groups. The first group, which is kind of close to my heart, is a total ankle replacement. What we do is basically when somebody has an arthritic ankle, which causes pain and inability to move the ankle, and really you can't move around because any step could cause pain due to cartilage deterioration. And in those conditions, which are mainly post-traumatic due to a previous fracture, is really debilitating and really causes a lot of problems to these patients. The older solution and the old gold standard for such a situation was an ankle fusion. Just fuse the ankle together, allow no movement of the ankle, and by no movement, there'll be no pain, which is a great option. But new researchers have shown the total ankle replacement, that by replacing the ankle, we could preserve motion, we could load off the adjacent joints, and just allow people a much faster rehabilitation. I was very lucky when I flew to Boston to train under Dr. Slavenkai, who's a world-renowned total ankle replacement guy, and one of the leading people, and he really taught me this technique. And I must say that at this point, after bringing the procedure to Israel, we have become one of the leading center, if not the leading center in Israel, in total ankle replacement, both in quantity and in quality, if I may say so myself, of this replacement and so on. That is one aspect. The second aspect, which is somewhat contradictory, is moving into minimally invasive surgery.
Okay.
We know that scoring is anesthetically pleasing, and it might cause other problems such as pain and other problems within the foot itself. So we kind of moved over to minimally invasive surgery. This is a trend which has been going worldwide.
Was that like laparoscopic for ankles? And
so yes, we do have arthroscopes, and we do arthroscopes for both the ankles and the tendons themselves.
That's why
we can go into the tendon and see the tendon itself and see if we could treat these conditions. But not only that, even fixing bony deformity, even cutting of the bone and fixating all of these things are being done with smaller and smaller incision, allowing much more rapid healing and ambulation of these people, and maybe better results to some extent.
Any robots involved in that?
Not in this extent. The foot is so frail, but it is coming. More and more people are going into virtual/augmented reality, into this complexity, but it hasn't been developed to that extent yet because the foot is just too frail in order to hold it into position.
Makes sense. So can you discuss a little bit about the role of non-surgical treatments? You just mentioned a lot of really new and exciting innovations in the surgical side. What do you typically recommend if not surgery?
So when treating a condition, I would usually say there are two options. You could either fit the foot to fit the shoe, or fit the shoe to fit the foot.
Okay.
Meaning we could do some kind of changes within the shoe itself, put in some insoles, put in a brace or so on, in order to change the biomechanical aspects of the foot and therefore fit inside a shoe. And that's changing the shoe. The other option is changing the foot, which
is the surgery.
Which is surgery, which we will be talking But usually I would start off with a non-surgical conservative treatment. We combined of non-steroidal anti-inflammatory drugs. I would maybe inject some steroids or some PRP, depending on where exactly the involved joint or pathological condition is involved. Put on a brace. And then only afterwards, if everything failed, and start obviously some physical therapy. Sorry about that. So I start some physical therapy, which is extremely important in such a thing. But if everything fails, after having again a discussion between myself and the patient, only then when we continue to changing the foot, pausing the foot and realigning the foot and making it more biomechanically stable in order to make it into a shoeable, braceable foot, allowing him the best quality of life and ambulation situation.
When somebody does end up opting for surgery, how long on average is the recovery time, and what other kinds of considerations does the person need to keep in mind?
Unfortunately, the recovery from foot and ankle surgery is fairly long. It does not mean they can't immediately stand on their foot. They could, such as the bunion surgery, which we previously spoke about, but still there's a lot of pain involved, and there's no way of going around it besides saying that we're breaking the foot and realigning it. So it does take a while. And when we come out and with the end product, he's walking, or he or she is walking around with a new foot, with a new kind of extremity, which he never had before. So the rehabilitation, although the immediate healing might be weeks, the rehabilitation might take months and sometimes even years. So there is a long time of recovery, but sometimes it's much faster than we think, which is great.
Interesting. Okay. I'm just thinking, I'm a runner, and I'm thinking, if I ever had a foot surgery, what would happen to my running? To how long does it take to get back to yourself?
Unfortunately, it does take some time.
We're talking months and potentially years.
Yeah, in some cases.
Can you share with me maybe a particular challenging, case or patient that you've seen that depicts, what goes on?
100%. So unfortunately, I had many patients, which really stuck to me, and we did manage to improve their quality of care. But I'll talk about one specifically, which had a very hasty recovery. We're talking about a 70-year-old lawyer who had a previous trauma to his ankle. It was about 10 to 15 years ago. And ever since, he underwent multiple surgeries in order to fix and to alleviate some of that pain which he had in his foot. He was fixed originally. Then they took out all of the instrumentation. Afterwards, they cleaned up all of that area. And unfortunately, he never had that pain fully go away. So he was referred to me by one of my colleagues, by my head of department. And I said, okay, let's do a total ankle. I think you're an ideal candidate for total ankle. This guy had a super hasty recovery, and he was sending me pictures of 3 months dancing along in Greece on uneven ground with no pain.
Wow.
And another sentence which kind of stuck to me was he woke up a few days post-surgery and he's like, I don't feel my ankle anymore. Is this the way people feel, that you don't feel your ankle anymore? And then he's like, I'm not feeling my other ankle too. I guess this is the way it's supposed to be. Wow. And that was really much amazing. And he's an amazing person.
It's really cool. So how do you collaborate with other healthcare professionals? Are there other physical therapists, podiatrists in the hospital that you work with on a regular basis?
100%. We do have a lot of additional participants. We try to do a multidisciplinary approach for all of our patients. Now, it's easier for the inpatients. So, for example, the diabetic foot unit, which is located within Hadassah and stuff, we do have a combined kind of multidisciplinary group which works. So we speak to the podiatrist almost on a weekly basis, to the physical therapist, to the nursing staff, to the social workers, from pharmacological people, and the social workers. We just do everybody, and we try to help the patient to the best of our ability by kind of walking around with everybody we can. Now, I do have also a direct connection also to physical therapists who are working outside of the hospital. A lot of them have my phone number, and they call me on a regular basis just to know how to better improve this condition with our patients, because rehabilitation is super important. As we said beforehand, it is a new foot, so people need to get used to it. They really need to understand, if I fix the instability of the ankle, if he's not going to do physical therapy, it's going to fail. So we might as well speak to them as much as possible just to realign and get the better outcomes for our patients.
Can you give any advice for actually making sure we don't develop foot pain? Is there like some kind of optimal plan for ensuring foot and ankle health?
It's a great question. And so the main issue I would say is just taking care of your foot. Just look at your foot daily. Okay. Foot could develop and go toenails, ulcerations, infections. All of these things are in the foot. And the feet, we sometimes forget about them. We don't walk on our hands, we walk on our feet. That's why they're very, very important. And you just need to look at them every day. Look to see if there's any pressure sores, to see if there's any ulcers, any deformity which is causing somewhat pain, and just be on top of it as much as possible. Wear a comfortable shoe. A comfortable sneaker is usually a great option in order to facilitate really decreased pressure of that area and to allow better healing and decreased pressure and load and pain of the foot itself.
Doesn't look as nice though to wear tennis shoes everywhere you go.
Unfortunately, that is true. That is very much, but unfortunately, that's what should be done. What can be done is might be a different issue.
Yeah. All right. So looking ahead, what do you see as the future trends or areas, of growth in the foot and ankle surgery?
It's a great question. So as we were saying beforehand, we both need to go larger and go smaller. We're going to go into larger surgeries. All of these people requiring total ankle replacements might need additional surgeries further down the line. We might see further down the line also some kind of complications. So we need to go bigger in these kind of conditions. On the other hand, we're going smaller and smaller. We're going into smaller incisions, minimally preventative surgery in order to stop all of these grave conditions, which we've listed beforehand. So that's the first aspect. The second aspect will be we want better censoring, better monitoring, better options of detecting and treating foot conditions before they become a bigger issue. We are now currently working with a commercial company regarding developing this kind of special shoe and insole in order to kind of facilitate that and decrease that and allow better healing and much faster diagnosis of these conditions. Besides that, I would also say we're trying to change the biomechanical aspects, not the mechanical aspects, but rather the biological aspects of the thing. We're trying to regenerate cartilage. I'm doing it with my colleague, Dr. Haze, which you've previously interviewed on this podcast. We're currently having a research program regarding regeneration of cartilage within the ankle joint in order to facilitate better healing of that area. So we're both working on the biological and the mechanical aspect of these conditions. And preventative medicine, I think, is the most important kind of medicine we could do, because if we could treat it when it's a small problem, we won't need to get to these big problems, which unfortunately we need to treat on a daily basis.
Makes a lot of sense. Well, Dr. Gellman, thank you so much for being with us today. We think all of our listeners have learned a lot. I certainly have. And so thank you for being on.
Okay. Thank you for having me.